Thanks for joining us this morning. This is a session today about medications, and here you're seeing that there are some upcoming sessions as well. We'll return to this at the end about what's coming up next. As in previous sessions, I'll just take a moment to reintroduce myself. My name is Paul O. I'm the medical director in the program, and you've logged in to watch a session about taking your heart medications. And some of you may actually be returning participants from our last session. So I thought I would change things up a little bit for today and focus on some new topics. As a point of ground rules, we'll remind the group that these sessions are for education only. And if you've got a particular question about your own medication list in this particular circumstance, we'd ask you to check in with your own healthcare provider, physician, nurse practitioner, pharmacist about medicines that are appropriate in your situation. We're very keen on hearing what's on your mind and would ask you to use the Q&A function of the Zoom to ask your own particular questions. Hopefully there is something that has been on your mind for the last while, and this would be a nice opportunity for us to have a conversation about that. So we will be covering today some information about common classes of heart medications. There's some good features and bad features about them. And in our last session from January, we did cover off a little bit more systematically the various types of medications that we might be exposed to. And we also did another session in January that talked about the diabetes medication. So both of those are available to you in the Cardiac College online archive section to view at your leisure. We also want to emphasize that there's a number of other resources that are available to help you manage your medications available at the Cardiac College website. And of course, we would really encourage you to check in with your healthcare providers about your particular medicines. Here are the topics that I thought that would be of interest for today's conversation. The first being, let's revisit some of these issues around antiplatelet medications, including aspirin and other agents. And in the last number of months during the time of COVID, there were some recent guidelines that were presented around the appropriate use of aspirin. And I thought that might spur on some questions in your mind. If you want the basics of aspirin, we did cover that last time, and we'll touch on that today. In terms of blood pressure medications, a recent topic that got a fair bit of media attention was the concerns with certain blood pressure medications and COVID-19 infections or risk of infections. And I want to touch a little bit about cholesterol-lowering medications, in particular what's new in terms of either guidance or agents that might be available. So we're covering A and B and C today as a nice adjunct to the kind of foundational session that we ran a few weeks ago. I'll remind you, or if this is the first time you're watching, that this is a nice framework that we use to think about our medications. So as opposed to just a list of medicines or bottles of pills, it's nice to give them some context about why medications might be important. And I'm sure you'll recognize that this is representing a coronary artery in cross-section. And under good circumstances, this artery is a nice open tube through which blood flows. You can see there's a lot of things that have gone wrong with this artery in particular. It's not a nice smooth tube that's completely open. In fact, it's completely blocked off. And that means this unfortunate person experienced a heart attack and had a bad outcome. What we learned from this person's anatomy and pathology is that there's a few things that happen over time, including this thing that looks like a crescent moon is the development of cholesterol plaque over decades of time. And this clearly doesn't belong here, but unfortunately is characteristic of many people who are living with heart conditions right now, that we develop plaque in our arteries. It takes many years to build up to this amount. And when we see an abnormality like this, or any of the other abnormalities on this slide, we think, well, maybe there's a medication or other kind of approach that might help me out with that. And of course, this is where cholesterol medications might come in. The other parts that we see, instead of being a nice smooth tube to conduct blood flow, this is quite irregular in nature. There's buildup, there's thickening of these walls, and this is the effect of blood pressure and other kinds of stresses on the artery. So blood pressure approaches are very important in keeping arteries healthy. And we're going to talk about blood pressure medications and again, the interactions with COVID. And then the third major abnormality here is this red oval that's in the middle. And this is a blood clot or a thrombus that was formed in the center of the artery of this person, which clearly doesn't belong there either. And we'll talk about medication approaches to prevent blood from clotting, and in particular, the use of aspirin in appropriate individuals, whether you're at risk of having problems with arteries in the heart or elsewhere in the body. Okay, so these are the ABCs for today. Now, so starting on the aspirin story and the orientation around blood cells, some of you might recognize this as a colored electron micrograph of, or a really close microscope section of blood cells with a backdrop of a little bit of bone marrow. So blood cells are produced by the marrow in our bones. From early cells, they grow and mature and then are released into the bloodstream. We've got three major types of blood cells. Quite appropriately, these ones that are red in color are called red blood cells. You see that they're nice discs with little dimples in them. And their purpose, of course, is when they are nice and red and healthy, that they are carrying oxygen around our body, from our lungs and heart down to our exercising muscles and other cells, and deliver oxygen to those sites so that we can carry on with all of our activities. This purplish colored cell here is colored purple, but is actually termed a white blood cell that is responsible for fighting infections. Of course, so critical today when we are facing a pandemic of infections. And then the other cells that need to be recognized and celebrated, because we've got a whole bunch of them. In fact, trillions and trillions of these yellowish kinds of cells. These are the ones that are called platelets. And their responsibility is for helping with our clotting and protection against bleeding troubles. This is another blown up picture of what these platelets look like under resting conditions. And you'll see that they are like pancakes or pita breads that are stacked, but they can stack and also unstack very, very easily. And that's their kind of resting state, that they're really not doing much in the moment, but they're getting ready to do something. And when the platelets get stimulated because of injury or bleeding or trauma, you'll see that these platelets start to stick out their fingers and start to link together. And this is when a platelet starts to get transformed and get activated and start producing clots. So we go back to our artery that is meant to be this nice open tube. There's the crescent moon on the left-hand side, representing that cholesterol plaque. There's this irregular surface. And when platelets go by here, they think, maybe there's been some injury or some other kind of trauma internally, and the platelets start to stick to that or adhere to that. So they think that they are doing some good work by preventing damage. But what unfortunately happens is if a whole bunch of platelets get stuck there, they can actually start blocking off blood flow. And at the time of a heart attack, for instance, what happens is that there is a rupture in the surface of this plaque that incites a whole bunch of platelets, and then red cells and other cells get stuck on this, that then produces that thrombus in the middle of the artery that really represents the event of a heart attack. So to prevent that, aspirin works very well at telling these platelets to calm down and not get sticky. And I showed you this slide in the January sessions. For orientation, on the y-axis, this represents the percent of bad things happening. So the higher the height of the bar graph, more bad things happen. And we're going to look at serious vascular events, stroke, and coronary events. And we're comparing two groups. The group in orange are the people that received aspirin, and the group in pink are those in clinical studies that received in placebo. And there have been hundreds of thousands of people who have been enrolled in research programs over the last several decades that have looked at the effects of aspirin as well as other kinds of antiplatelet drugs. And very consistently, this is the observation that people who take aspirin enjoy a lower rate of bad things happening, like serious vascular events, stroke, or coronary events, compared to people who don't get aspirin. And the effect is about 25% or so. So certainly better just to take a little baby aspirin. And for those at higher risk of developing thrombosis types of problems, aspirin plus something else will even lower this even further. And that's why some of you are taking not only one blood thinning medication, but two, or even maybe more, to try to really thin the blood out. Okay, so I think that's information that is quite well known to each of you. Here's some of the interesting stuff that's happened over the last year or so. In May of 2020, there was a new guideline on the use of aspirin, or its long chemical name is called acetylsalicylic acid, for the prevention of cardiovascular disease. And every time one of these kind of medical articles comes out, there is a bit of media pickup, and sometimes the nuances of the story don't come out particularly clearly. And I'm very sympathetic to our patient partners who may be left wondering, well, should I be doing something different about my aspirin? Is there something that's new that will cause me to change my course? So that's why I thought it'd be worth just chatting about this today. And the guideline that was in question came from the Canadian Stroke Network, their best practice recommendations for the use of aspirin, acetylsalicylic acid, for the prevention of vascular events. And the Heart and Stroke Foundation collaborated on the development of these recommendations and also provided some information on their own website about the use of ASA for prevention and what you need to know. So I think for folks that might be watching this particular educational event, most of you will fall into bullet number one. And the first key point is that aspirin is still strongly indicated for the secondary prevention of patients who have had a cardiovascular event, a stroke event, or a peripheral arterial event. So if that resembles your kind of medical story, that you've had a heart attack, a stent, a stroke, a warning stroke, you've got blockages in your legs, aspirin is still a fundamentally important therapy to protect all the parts of your blood vessel system to prevent that thrombosis from happening. Point number one. Don't change. If you're taking aspirin 81 milligrams because you've had a vascular event, keep taking that. Where the story starts to shift is what we start to tell people who have never had a cardiovascular event, a stroke, or a peripheral arterial event. That is, if you're a young, healthy person, in particular, a young, healthy woman, in decades past, we might have said, well, aspirin for everybody might be a good idea. But the emerging literature over the last number of decades has indicated that maybe that's really not the case, because even a little baby aspirin a day does have a little bit of risk associated with it. And some of you may have actually been through the challenges of a little baby aspirin causing irritation to the stomach, for instance, causing ulcer, causing bleeding. Other people, even though the risk is very small, there is a small risk of bleeding into places like the brain on a little baby aspirin. So we have this kind of trade-off situation. And as your risk goes up for developing vascular problems, it makes it therefore much more worthwhile to take that little aspirin. If, on the other hand, your risk is very low, you're perfectly healthy, and I pick on women because young women have very little in the way of cardiovascular disease for the most part, with a few exceptions. And in that situation, taking an aspirin for everybody probably isn't a good idea. So the recommendation number 2 is that aspirin is no longer recommended for the primary prevention in individuals without a history of these kinds of vascular problems, because the concerns about harms. Instead, we should be focusing on primary prevention. And I would argue we've always wanted to focus on primary prevention through healthy lifestyle choices, lifestyle modification, and thinking about other vascular risk factors. That's not new. We always want to do this stuff, but really position the aspirin for those at higher risk. If you are taking aspirin right now and have been taking it for some years or longer, and you're wondering whether you should continue, well, this is an opportunity for you to chat with your healthcare provider about the role of aspirin in your own particular situation. What is your risk? What is your concern? Is it that somebody in your family might have had a vascular problem, and how does that enter into the equation? The guidelines also point out that there are still some questions, some areas where we really don't know. Like if you happen to have undergone a test of the arteries in your neck looking for early narrowing, or you might have had a scan of your heart that might have shown that there's some calcium in the arteries. In those situations, some clinicians today will still say aspirin is probably reasonable to take, and especially if you've been taking aspirin for some period of time and it's agreeing with your body. But the definitive information about some of those scenarios is still kind of being worked through. The clear things on the ends are secondary prevention, take your aspirin, low risk, otherwise healthy, don't take aspirin, and there's some gray space in the middle. Okay. Number 2 was around blood pressure medications. And in previous sessions, we would have talked about medicines like the beta blockers, those that end in LOL, and the good role that they have in controlling blood pressure and heart rate and calming down the blood pressure system. Some of you might be taking calcium channel blockers, drugs like amlodipine or nifedipine or diltiazem. These are medicines that also calm down the heart, relax blood vessels, open them up, and thereby lowering blood pressure. And those remain very good interventions to lower your cardiovascular risk. In the time of COVID, though, there were some headlines about a year ago, early on, that said, perhaps that there are some concerns about certain blood pressure medications, specifically the ACE inhibitors and the angiotensin receptor blockers. And this led to some mild panic in the patient community and a little bit in the medical community as well. There are certainly lots of articles and editorials written about this area, and some sound guidance was required. And the concerns were stemmed from a couple of articles that were ideas only, really only ideas. But this was one that was published in the March issue of the Lancet Respiratory Medicine Journal. The Lancet is a very prominent British medical journals kind of group. And then this one was published that talked about a theoretical concern that when one looked at how the COVID virus stuck to cells in our body, like in the lung areas, they did so through an angiotensin converting enzyme receptor. The notion that if you use certain kinds of blood pressure medications that try to interfere with that system, you might actually cause more of these receptors to come up. And then theoretically, that might allow for greater penetration of the COVID virus into the human body. This was a theory, but it got a lot of attention because we were looking for concerns about anything that we could do to mitigate the risks of COVID. To remind us about this whole angiotensin system, reminder that we have hormones in our body that interplay with our blood pressure system. There's a hormone that is called angiotensin that is formed through an interaction between the lungs, the blood, and the kidneys. Angiotensin, if you think about the word, angio refers to kind of the blood vessels and tense refers to tense. So if you think about fists squeezing, this is kind of the effect of angiotensin on the blood pressure system, which is not so friendly, but we have some people in society that are kind of wired this way with too much tension in their blood vessels. So if that is a reason for having high blood pressure and making blood vessels squeeze, then over the last probably 40 years, we've been aware of medications that can actually work on this angiotensin system to allow for relaxation, lowering of blood pressure, protection of the heart, really great outcomes. And we could do this through two different mechanisms, either through the inhibition, that's what the I stands for, of angiotensin converting enzyme. And we're familiar with this whole pathway because many of us are taking these medications that end in pril, like ramipril, lisinopril, perindopril. These medications block the formation of angiotensin in the first place, thereby allowing blood vessels to relax. And under usual circumstances, we say this is a very desirable outcome to have a calm, smooth blood pressure system. For others, instead of taking an ACE inhibitor, we might offer you an ARB, an angiotensin receptor blocker. So instead of preventing angiotensin formation, these medications block the action of angiotensin. And you'll know them because they end in sartan. So if you look through your medication list and you're on irbesartan, candesartan, olmesartan, telmisartan, you've got the cadence of that. That's what these medications are about. And these medicines are also really good at relaxing blood vessels, lowering blood pressure, protecting your heart, protecting your kidneys. So really kind of good idea. But putting this into the context of COVID, at least theoretically, again, COVID virus with its spiky proteins could enter the human body, either through the gut or through the lungs. And theoretically, the spiky protein on the COVID virus can attach to the angiotensin converting enzyme 2 receptor on human tissue, like the lungs or on the gut, theoretically. Because some people are taking these ACE inhibitors or angiotensin receptor blockers, the ACE2 levels may actually go up. Because when you block a system, it responds by sending out more signals, and maybe more of these receptors actually go up. So the theory was maybe the infection risk would also go up. That's what was in that kind of hypothesis article from March of last year. So then this led people to start looking at, well, is this really a true idea or is it just kind of a theory? And so the question number one was, if this is true, if this theory is true and that these medicines might be causing potential harm, then we should be able to pick up a signal. If we ask a question like, are people with high blood pressure more likely to get COVID-19? That might be the starting point. So when this was looked at in the early hotspots of COVID in the spring of last year, like in China and Italy, the finding was that about 15 to 30% of people who are hospitalized with COVID-19 had a background of high blood pressure. All right, so this maybe elevates our concern a little bit more, but it's important not to look only just at this one side of the story, but it's important to look at the other side of the story. That is, that if you look in the general population of adults, about 15 to 30% of adults have high blood pressure. So this number up above is really no different than what's happening in the general population. The vast majority of adults were not infected and they were not hospitalized. So blood pressure is one of the things that emerges as a concern, because it's a concern for all kinds of medical issues, but not necessarily COVID. It didn't give you extra risk in particular. And then if we look at more specifically the use of these particular agents, again, turning to that report from China and Italy, of the 15 to 30% of people who were hospitalized and had high blood pressure, about 15 to 30% of these people were on one of these therapies. But the signal was not any higher for people that were in hospital or for people that were not in hospital. So it didn't seem like the fact that people were on medications actually led to any more hospitalization than not. And there was even some alternate commentary theory in the literature that said, you know what, maybe these medications may in fact be beneficial and protect people from developing severe pneumonia. And so it's interesting how debates will form when people are just posing ideas without necessarily really good data. So there wasn't enough data to support that it was bad. There wasn't enough data to support that it was actually good, but it did lead to a whole bunch of people trying to create some clarity out of this. And one of the leaders in the hypertension area, Dr. Bacchus, wrote this editorial that this is a big controversial issue. There is no clinical data that supports the hypothesis that people taking ACE inhibitor drugs or angiotensin receptor drugs are more likely to be infected with the COVID-19 virus. It was a hypothesis based upon animal data. We do not need sensational journalism on this matter. We need stability. And then the advice back to patients was that people should really just keep taking what they were supposed to be taking. The World Health Organization weighed in and created their own scientific brief about this. The likelihood of severe disease, if anything, was a little bit lower on people taking these medications. It certainly didn't increase the risk. And then a number of cardiovascular societies from Canada, from Europe, from the US said that we really need to just put this to the side, advise folks not to stop taking blood pressure medications unless you have specific advice from your physician. And the concern is not about COVID. The concern more is that if you stop taking your drugs suddenly, this will lead to uncontrolled high blood pressure and hospitalization. And that was the real concern about that. So that was ACE inhibitors, angiotensin receptor blockers. The other medications, there really was no concern about them. So if you're on an LOL beta blocker, keep taking that medication. I'm just going to skip through this stuff. And then come back to the cholesterol parts just for the last part of the conversation today. And a little bit old, a little bit new today. The little bit of old stuff is just to remind us about the older kinds of medicines and the importance of cholesterol in our ABCs of protecting our hearts and our blood vessels. A reminder that cholesterol comes from a couple of different pathways. About 25% comes from our diets. Very important to have a good, healthy diet. But if we really want to work on cholesterol values, that we need to work on the liver side of the house as well to really push the numbers down, because the liver is the main place where cholesterol is produced and recycled and handled throughout the body. So in addition to good diets, often we need to rely on some medications. The use of medications is predicated on our understanding of how cholesterol is handled within the body. This again represents our liver, where the major site for cholesterol production kind of comes from. Small building blocks like these small-ish particles are joined together to build longer complex molecules, eventually ending in cholesterol. One of the key steps that occurs along the pathway takes this intermediate product called HMG-CoA and transforms it into mevalonate, which is a slightly bigger complex molecule. And it is governed by this key step here called HMG-CoA reductase. Think of this like a factory along an assembly line, or an assembly line inside of a factory, where this is the key step along the production line. HMG-CoA reductase is so critical that if you can shut this thing off, you will reduce the amount of cholesterol that is actually produced coming out of the liver, that then ultimately will end up in blood vessels. We love to it's important to remind us that we want to minimize the amount of LDL that is in our system, and ideally would target a value of less than 2.0 or so. So this stuff, HMG-CoA reductase, can be blocked using medications like statins, and this is very familiar to us. And this is the reason that we actually use statin drugs when we are trying to get cholesterol values down, because they are working at the level of the liver, blocking this key assembly line in the factory. So hopefully that's really quite clear. So when the statins block this stuff, they can reduce the production of cholesterol by about 50% or so. So there is less that's traveling to our blood vessels. And in fact, there's going to be some of this cholesterol now that returns back to our liver, because we need to have at least a small amount of cholesterol that's cycling around so the liver can do its job of producing things like hormones and cell membrane building blocks and other things. The LDL that kind of circles around here is recycled at the liver through LDL receptors. And we're going to turn back to that concept in just a second. But here you see the very nice cycle of this, and where statins are interrupting that cascade. That stuff is known to you, and this is why many of you are actually taking one of these statin medications, and many of you are taking one of these statin medications in particular, atorvastatin or rosuvastatin, because those are the ones that have the greatest impact on LDL lowering, because they are blocking more of that key rate-limiting step of the HMG-CoA reductase. That's known to you. If we can get 50% lowering of cholesterol, then that actually translates to less cholesterol in our arteries. That translates to less risk of developing a vascular event by doing so. Some of the newer stuff that's actually quite interesting is that if we return to that liver cell and think about how cholesterol gets transported back into that liver cell, this next part of our discussion talks about the role for new medications. And some of you might be taking some of these newer cholesterol-lowering medications, like this thing called a proprotein convertase subtilisin kexin type 9 inhibitor. I'm going to wager nobody would say I'm taking one of those things, but somebody might say, yes, I started on a new injection to lower my cholesterol. And that's the thing that we are talking about. When we are thinking about LDL being recycled at the level of the liver, this is what's happening on a kind of closer inspection. That the idea is that if we think of LDL as these kind of tennis balls with the nice kind of coloring, that when they're floating around through the bloodstream, we've alluded to the notion that these LDL particles will attach to this maroon colored squiggly thing that is an LDL receptor. So they grab a hold of each other and they get internalized into the liver cell to get processed. But you'll see in this cartoon that there are these other kind of pinkish things that look almost like kidney beans. They are part of this equation as well. So you'll see that the LDL particle attaches to an LDL receptor. But the third component here is that the LDL particle and this kidney bean and the receptor all come together. This thing is called the PCSK9 molecule. And when those three things come together, then it gets internalized into the liver cell and gets broken down. Everything gets broken down in this kind of digestive package called the lysosome inside of our liver cell. So you'll say, well, this is not a terribly efficient thing that's going on because I just want to take some building blocks out of the tennis ball, but you made me break down everything. The problem with this kind of a program is that it's not terribly environmentally friendly in a way. And also we chew up our LDL receptors in this process also. So it led some bright people to discover about a decade ago that if we kind of change up this system, that we might have an opportunity to actually recycle some of our LDL receptors. The way that we might do this is that if we can block off those PCSK9 kidney beans using an injected substance, a monoclonal antibody that binds specifically to these PCSK9 molecules, it now leaves the LDL receptor free to join with an LDL particle just as a two-part reaction. And when that two-part reaction happens and the particles are ingested into the cell, that now the body recognizes, or the liver cell recognizes, look, I can actually just take the tennis ball, break it down, and I can actually recycle the LDL receptor and send it back to the top. So now I've got more LDL receptors that are looking into the circulation to grab more LDL particles. What a really interesting kind of mechanism that was created. And then these PCSK9 inhibitors have now been used in many people as an injection taken every 2 to 4 weeks to build up more of these LDL receptors, drag out more LDL from our circulation, and lower LDL by about 50%. So that's very interesting. And again, some people are receiving these kinds of therapies, especially if the LDL levels are too high, just taking a statin. Coming down the medical cascade in a little while is one other therapy that can actually be injected into the body every 3 to 6 months. So instead of the prior PCSK9 therapies that were injected every 2 to 4 weeks, you might be able to get away with an injection only twice per year. And the way that these new molecules like inclisiran will work is not by directly binding to these PCSK9 molecules, but actually by blocking the production of them in the first place. The net effect is very similar, that if we block PCSK9 production, the LDL particle can attach to the LDL receptor, get internalized, get recycled, and we still get a whole bunch of LDL receptors produced. So this is kind of very interesting ways of continuing to modify our environment so that we have less cholesterol produced, less things sticking into our arteries. Okay, so that's the new part of the ABC story, the C cholesterol story that's coming out. Just a reminder that there are some side effects with cholesterol medications, and particularly with the statin drugs. We're looking for muscle aches and pains with big muscles. With these newer therapies, we are not really seeing any additional side effects. There are some people who report muscle aches and pains on the injections, but probably because you're taking the injections at the same time you're taking the statin drugs. That is, they work better together, and the side effects probably relate to the statin drugs in particular. Okay, I have talked a whole bunch over these last 40 minutes or so. I wonder if there are any questions and answers that are questions that you might have, and that any answers I might be able to provide at this point. While you are thinking about that, if you'll type them into the Q&A box of the Zoom platform, I'll just share some ideas about things that are coming up, and I'll keep watching for your Q&A. If you don't have any questions by the time I get through what's coming up, I'll assume that your questions have been satisfied for today. Okay, so moving on to what's coming up next. Very exciting week. That this week we are celebrating Wear Red Canada Day. Indeed, there's a national conference that's going on this week about women's heart issues through the Canadian Women's Heart Health Centre. Every year for the last number of years, there's been a day designated in February to champion the importance of women's heart health and increasing awareness. So we will be hosting some events on our site. And if you look at our Cardiac College Online live events calendar, you'll be able to join into a session called Her Heart Matters, Wear Red Canada, through the events calendar page. And if you'll make a sensible wardrobe choice on Wednesday, wear something that's red to celebrate Wear Red Canada Day, that's terrific. You'll just look fashionably stylish one day in advance of Valentine's Day as well. So take advantage of that for Saturday, February the 13th for Wear Red Canada Day, and link in for an educational session. We also want to let you know that Healthy University is now live on social media, and there is a Twitter handle that's been set up for Healthy University. If you'd like to sign up and follow us on Healthy University, then we will send out information regularly. Our team project leads will be sharing information on a regular basis through Twitter. So at healtheu_TRI, you'll stay up to date with happenings in the Healthy University and at Cardiac College. Our next session with you and hopefully more of your colleagues will be happening next week on Wednesday. I will deliver another live session about how your heart works, the anatomy, the pathology, as well as therapies. And again, if you've got some questions about what's happened with you, then your questions will be welcome at that session next Wednesday, February 17th at 2 p.m. All right, well, that brings us to the end of this. I'm checking the Q&A box one more time. I don't see anything else that's come in. I'm going to assume then your curiosity has been satisfied today. I want to thank you for joining us for another Cardiac College online session, and we'll look forward to connecting with you again in the very near future. I'm wishing you all a wonderful day. Take care.